Hello, everyone. Thank you for watching my presentation on the cost effectiveness analysis of the Strongest Families Neurodevelopmental Program. I'm Aranie Vijayaratnam, MSc candidate at the University of Toronto Institute for Health Policy Management and Evaluation, supervised by Dr. Wendy Younger at the Hospital for Sick Children. For this presentation, I'll be going through a brief background and rationale for this project, as well as research objectives, then followed by some methods and preliminary results, followed by some next steps. So the background behind the Strongest Families Neurodevelopmental Program is that children with brain-based developmental disabilities are likely to have emotional and behavioral challenges, develop depression into adulthood, and have an increase in disruptive behavior. This is often untreated or undetected in the general population and negatively impacts the child's quality of life of their families and/or caregivers, and negatively impacts their functioning, such as in the form of language acquisition and self-direction. Varying treatments and interventions are available at different stages of life. For this specific study, we'll be focusing on parent training. What is parent training? It is a well-established, systematic approach that guides caregivers on changing their behavior and also improves communication with their children. The goals of parent training are to increase self-efficacy in caregivers, increase social behaviors of their child, and reduce core symptoms and neurodevelopmental disabilities, such as restrictive behavior. There are many types of parent training, and they usually fall between these broad categories: virtual, such as telehealth and video, language and communication focused training, interaction and play-based training, and behavioral management. Each treatment comes with its own pros, cons, and associated costs. The Strongest Families Neurodevelopmental Program is a virtual training program. So the Strongest Families Neurodevelopmental Program is part of the Child Bright Network, and it is a randomized controlled trial. It is a 3-armed RCT, which compares groups at 2 5-month intervals starting from intake. Enrollment began in September of 2019, and the final follow-ups ended in September of 2022. At baseline, there were over 400 participants. At 5 months, there was a drop to around 328, and then at 10 months, 330. The 3 groups are as follows. The main group of focus is Group 1, Group Coached. They are receiving the main intervention, which is the internet-based parent training program, which includes telephone group coaching with a coach, followed by access to a parent-to-parent forum. Group 2 does not receive the training from a coach. Instead, they have access to the parent-to-parent forum, while Group 3 is the control group. They just receive a static web page with resource links. So the main focus of this project is to compare the incremental cost and incremental effectiveness of children receiving all 3 of the intervention groups. And we're comparing it from 3 multi-payer perspectives: societal, provincial, and families. So our hypothesis is the Strongest Families Neurodevelopmental Program good value for money when it comes to treating children with neurodevelopmental disabilities? The methods that we will be using to look into this program are 2 key metrics: Resource Use Questionnaire, the RUQ, and the Health Utilities Index, the HUI. We also looked at demographic data, which includes location, caregiver, and education and income, and the child's diagnoses, both physical and mental. The Resource Use Questionnaire is designed to gather information with services that children with neurodevelopmental disabilities use across a variety of sectors, as well as their associated costs. So this measurement also only collects information that's relevant to the services that may impact the improvement of a child's emotional regulation. We want to be able to capture the breadth of services this population may utilize. And it has been validated in previous studies with children with autism. The Health Utilities Index is a general health status and health-related quality of life measure, and it provides a descriptive evidence on different dimensions of a health status, a score for each dimension of health, and then a health-related quality of life score for overall health. Some of these dimensions include speech, vision, mobility, with dimensions having 3 to 6 levels. Overall, health-related quality of life scores are used to calculate quality-adjusted life years. For my costing analysis, we looked at all costs relating to the Strongest Families Neurodevelopmental Parenting Program. This includes salaries, benefits, travel costs, etc., that are included in this analysis. The resource use questionnaire captures all levels of health and social service usage, including interventions for challenging behaviors such as social work for usage, medication, respite, etc. Prices for interventions, services, and medications, and any other costs were collected from study partners, provincial program administrators, fee schedules, and governing colleges and published sources. We also captured productivity losses, and we're using the human capital approach to quantify productivity loss, which is the volume of lost paid and unpaid labor time multiplied by the Canadian average age and sex-specific wages. This was pulled from Statistics Canada. And we calculate the total cost per child by multiplying each item of resource use by its corresponding unit price. So if somebody visited a psychologist once a week for 5 months, it would be 1 times 4 times 5 times the price of the psychologist. This would then provide a mean cost per child, and it was separated by intervention and comparator group and from each analytical perspective. We also incorporated provincial autism programs into the costing analysis. A large proportion of this study participants reside in Ontario. Thus, we added a cost weight for participants that indicated that they have a child with an autism diagnosis. If they are under the age of 6, there was a $22,000 add-on. If they were over 6, it was a $5,000 add-on. This will be adjusted to other provincial autism programs through scenario analyses. The analysis for effectiveness is where the Health Utilities Index comes into play. It allows for the calculation of quality adjusted life years. Individual responses are mapped to a classification level and then will be assigned weights. These weights will then be scored statistically to produce a single utility, and then the mean utility per child by group will be calculated. The overall utility will inform which health state an individual falls under, and these range from 0, death, to 1 of perfect health. Then the cost effectiveness analysis is produced by the HUI and the mean cost per child with the resource use questionnaire, and this will then be calculated into an incremental cost effectiveness ratio, an ICER. This intervention would be assumed to be cost effective if the monetary benefits are higher than the costs. This will be displayed in a cost effectiveness acceptability curve, a CEAC. Here are some preliminary results that we have found so far. Here are the provincial distribution of the intervention groups. As you can see, Ontario has the highest amount of participants residing, followed by Alberta and British Columbia. Many did not disclose their primary residence. These are the most commonly reported services throughout each interval: speech language pathologist, occupational therapist, and applied behavioral analysis therapy. As you can see, there is a drop by 10 months from some of these services. We also looked at the distribution of prescription medication over the study period. Stimulants were the most commonly used medication, followed by antidepressants and anticonvulsants. And these are the total costs at baseline. So for the familial perspective, this includes out-of-pocket costs. Group 1 had the highest cost at baseline. And then at the provincial level, this includes costs that provincial governments are paying for services. And this includes any incorporation of the Ontario Autism Program if a child has an autism diagnosis. The societal cost is the total cost of the service, regardless if the family or the province are paying out of pocket for. This also includes insurance payout. Unfortunately, due to the limitations of the study, we do not capture how in-depth insurance provides coverage for families. So this cost may be an underestimate or an overestimate of how much private insurance covers for. And here we have the cost at 10 months. The societal perspective still remains the highest, and that makes sense because this is the total cost of both the familial and provincial plus the unknown private insurance cost. Our next steps is to finalize the effectiveness analysis to produce the mean effectiveness per child, calculate the incremental cost effectiveness ratio, and then what do these results mean in the grand scheme of treating children with neurodevelopmental disabilities. Thank you.